there. All right. Hey, Dr. Prakash, how are you?
Hello, can you hear me?
I can hear you. It's so nice to see you. It's very hot in my office, so if you start seeing sweat, there's no air circulation in here. I'm sorry. So just the format tonight, everybody, you can, of course, start typing your questions, but it's going to take a while before we're able to answer them. We're just going to talk here just a little bit about some of the topics that we have going on this week, and then we're going to turn it over to you and let you start firing away with some questions. So, as you heard me say, this week we are focusing on aneurysms. And so today we had some information up about abdominal aneurysms, and tomorrow it's thoracic. And we were hoping that maybe you could just talk a little bit to aneurysms, maybe why they happen, where they occur, what it means. And we're just going to talk a lot about the different therapies and ways to fix them or not, and what goes on. So I'm just going to let you take the floor there and tell everybody a little bit about yourself, and then you can have that and start talking about aneurysms.
Great, well, thank you. I'm here at the University of Texas at Houston, and I work as the cardiologist in our aortic disease clinic with genetically mediated aortic disease of all kinds, including some that runs in families and some that is sporadic. My professional interest and research interests coincide. I work on genetics of bicuspid aortic valve and aneurysms and dissections related to Turner syndrome. And I also work as an echocardiographer or an imaging cardiologist in our local hospitals here in the Texas Medical Center. So my long-term interest is taking care of patients with aneurysms and those who've also had aortic dissections. I can talk a little bit about aneurysms, I guess. So almost all aneurysms have at least some component of a genetic cause, whether they occur in the chest or in the abdomen. Now, the structure of the aorta is not the same in different parts of the body, and so the causes of aneurysms can be very different depending on where they occur. The area that I work on in the chest is almost all driven by genetic disease. We know that because in most cases, we can either find a gene or we can find some evidence of a familial inheritance if we study patients with thoracic aortic aneurysms. But still, even in patients that inherit aneurysms, the risk to have enlargement or dissection depends on other factors besides genes. The most common factor is high blood pressure. Patients with high blood pressure are much more likely to develop larger aneurysms and to develop dissections. And we also know that certain medications can interact with your risk to have aneurysms. We prescribe medications, and as a cardiologist, I often follow patients who are taking different kinds of blood pressure medications to prevent enlargement of aneurysms. So there are all kinds of questions I routinely get asked, like medications, imaging, the frequency of follow-up, and when to have surgery are probably the most common ones. And I'm sure that many people have questions about those areas.
Okay, so if typically, and I hope you don't mind me jumping in as I'm writing them down, because you know, Pumphead, if I don't say it, I'm not going to remember. I've got post-it notes everywhere. So you're saying typically an aneurysm that's found in the thoracic area, which would be where it meets with the heart up until, I guess, midline chest, correct? Right. Would more than likely be some genetic component to that. Correct. And then from midline down might not be genetic. So what would basically cause an abdominal?
So abdominal aneurysms, we know, have a strong genetic component, but it is also driven by factors like smoking and high blood pressure and high cholesterol, which are more common in the population. So that is one reason why abdominal aneurysms tend to be much more common. And if we do population-based screening, we can find up to 5% of older individuals have some abdominal aortic aneurysms, although not all of them will need surgery for them. It is much more common than thoracic aneurysms. And a very different set of people and risk factors are associated with abdominal aneurysms.
So let's do scenario A. Patient comes in, for whatever reason, they end up having what test would someone typically have that would find an abdominal aneurysm? A CAT scan, usually?
So if an abdominal aneurysm is being screened for, ultrasound is the most effective way to do that. And we do recommend that certain populations do get screened with abdominal ultrasound. Most of the time, when we don't suspect or are not looking for an abdominal aneurysm, a CT scan would be the way it's caught, usually as an incidental finding when something else is being looked at.
So patient A, you find out that you have an abdominal aneurysm. What would be the next thing that a patient should do? What number, and I know it depends on different situations too, they receive a number of up to what is typically done, and then after that, what's typically done with an abdominal aneurysm?
Right. So typically, we start to consider the abdominal aorta abnormal in size when it's over about 3.5 centimeters. And then above around 5.5 centimeters is when most doctors would become concerned enough to indicate that the surgery would be likely in the near future. Now, in most cases, abdominal aneurysms can enlarge silently without any symptoms for years and reach up to 6 centimeters before there's any indication of a problem. That problem could be abnormal blood flow, pain, or other factors that may not even seem like an aneurysm to the patient. Many times the symptoms that they present with can be very nonspecific. So abdominal pain can be interpreted as anything except anything other than an aneurysm. There are many common causes that would be looked at first and could mislead, the diagnosis for a long time.
And so a patient comes in and it's, let's say, 4.2. What would be the typical course of action with that patient?
Well, if the physician determines that there are no symptoms related to the aneurysm, and then the next step would be to control factors like high blood pressure, have the patient stop smoking, maybe treat high cholesterol, and then you look at the family history, and if there's no family history of dissection, it's not necessarily an urgent situation. The patient could be monitored carefully with periodic ultrasounds or CT scans, depending on how it can be best assessed. And that would be determined by a trial set of images. And also to make sure that there's no other aneurysm besides that region of the aorta. If all that's true, then there could be a surveillance period of 6 months to a year and to see if the patient is stable. So if the aneurysm is enlarging or not. And
Okay.
if it's monitored and it's stable, then there wouldn't necessarily be a strong indication to proceed to surgery right away. You'd have to see some change or symptoms related to it that are new before you would decide to change course with your treatment strategy.
Now, do you put patients with that type of size, let's say 4.2 or below, on lifting restrictions as well?
Yeah, most people would recommend to avoid heavy lifting, meaning like lifting that you would have to strain with or heavy weights, because of the risk that we associate with heavy lifting and pressure in the abdomen and chest that can be risky for patients with large aneurysms.
So before I go on to what happens when it hits 5.5, can you explain the importance of the weight lifting restrictions and the non-straining advice? Explain the whole vasodilating. What does that mean and what happens?
Right. So we are specifically talking about isometric types of exercise, and those should be distinguished from aerobic types of exercise. Isometric involves lifting in place, so you're not moving, but you are straining, and that straining feeling is what transmits pressure to the blood vessels in the chest and abdomen. So for that reason, we specifically limit isometric type of exercises more than aerobic types of exercises. Now, aerobic exercise like running, movement-based exercises are not necessarily benign because they can also raise blood pressure, but they're less likely to lead to the drastic increases in blood pressure that are associated with dissection.
Okay. So now you're the patient that comes in and you're at 5.5 or above. What's typically the treatment there?
Okay, so aneurysms in the lower chest and abdomen do not necessarily need to be treated with open surgery. There are options like stents, which can be used to treat a localized aneurysm. but it depends on exactly where the aneurysm is located. And so the treatment could be different for different patients. There's no one-size-fits-all treatment. But in general, the options are, there are lots of options to avoid an open surgery, which, as you know, is associated with longer recovery times and more significant complications. And that would generally be related to the type of treatment that would be used to address aneurysms that are localized to, say, below the kidneys and are readily accessible to those kinds of measures. So there would be different kinds of preparatory procedures to determine if a patient is a candidate for a stent versus an open procedure. Imaging to again, look at the extent of aortic disease. They would have to have blood vessels that are amenable to placing the stents. So if there's a lot of atherosclerosis, for instance, it could limit the access that the physicians would need to place a stent. And if there's other sorts of disease that would make the patient a poor candidate for a surgery. So things like lung disease, other kinds of heart disease, they would all have to be assessed before the patient could be considered for different types of procedures.
Okay. So going into scenario 2, patient B, who has a thoracic aneurysm, and it's a fluke. They end up having an echo for some reason, or again, a CT scan, probably something unrelated, and it's caught. Because would you typically have symptoms with a thoracic aneurysm?
Probably not unless it was an extremely large aneurysm and it was located in a place that would press on other organs. So almost all the symptoms related to aneurysms are either caused by direct pressure, if it's enlarging enough, or if there's a dissection related to the aneurysm. Otherwise, they're completely asymptomatic in most cases.
Okay, so patient comes in for unrelated issue and they have an aneurysm on their arch that's 3.5. What do you do next?
Right. So an isolated arch aneurysm of 3.5 is not necessarily, again, a cause for concern, particularly if there are no other diseases of the blood vessels. The main risk there is, of course, if the aneurysm gets bigger, it can impinge on blood flow to the head and neck because those are where the branch arteries to the head and neck come off. And so you need to really get a precise indication of how extensive the aneurysm is and whether it affects those branches of the aortic arch. That can be with a CT or MRI, and also to exclude, again, other aneurysms that could affect the need for intervention.
Okay. Patient comes back in for their follow-up, and now they're at 4.8, 5 centimeters, maybe 5.2. What happens now?
Right. So if the aneurysm is enlarging rapidly, as in this case, then it would be a clear indication for an intervention. In most cases, aneurysms of the arch would need to be addressed surgically, and there are lots of different options. In the case of involvement of the branch vessels, that would include a bypass of one or more of the neck vessels in the aortic arch. And so it's a significant operation. There is a potential risk for stroke and for other kinds of complications that can be quite serious. And so you need to have a long discussion with the surgeon about the type of operative approach, which would depend upon the extent and location of the aneurysm in the arch. There are many different options now that didn't used to exist because we have more sophisticated grafts and stents that can be combined with surgery, which we didn't used to have.
Now, when somebody, we're not going to get into the details of dissections, but once somebody has had a graft, is it typical that at the anastomosis or where the attachments are that they may develop an enlargement in those areas? Is that typical or atypical?
It's actually very typical to develop an enlargement immediately distal or after where the graft has been sewn into the vessel. The reason for that is that the blood flow in that area is normal because at the interface of the graft and the tissue, there can be what's called a turbulent flow. And that turbulence can put pressure on the normal tissue that is right immediately after the graft. So that's the area that we most frequently need to monitor after any kind of surgery, but particularly if there has been a dissection that has been repaired, because we know that tissue is also weaker in that case.
Now, if somebody has a bicuspid valve and they've had an aneurysm repaired in their arch. Are they, do you know if they're at further risk to develop any additional aneurysms or have any other issues because of that valve? Does that lead somebody to have a higher propensity to having a situation later down the road?
Well, we know that bicuspid aortic valve is a genetic disorder, and so therefore the ascending aorta and arch in those patients is never normal, even if it is of normal size. And so therefore, if there's an aneurysm, those patients are in fact more likely to have complications, particularly if they've had extensive aortic disease. And we do recommend that they are monitored afterwards. It is somewhat controversial as to whether or not the valve itself contributes to propensity for aortic enlargement or dissection due to abnormal blood flow related to the valve. But that can be clearly demonstrated that those patients have abnormal blood flow in the aorta. And it is a concern if the bicuspid valve is not repaired and it becomes degenerative because that blood flow becomes more abnormal over time.
Okay. Before, I haven't been looking to see if anybody can post some questions. I took that off my screen, so I don't want to be distracted. I wanted to talk a little bit more about blood pressure. That is always a very big, important thing. Lots of questions in the community. And I think it's one of the leading question when you've had surgery or you find out that you have an aneurysm is how important is blood pressure? What is a spike? Is it okay if it rises when you've had exercise? At what point do you call the doctor? When is it like more of a pattern and a trend? So there's a lot of questions around blood pressure and patients. So if you can talk to that, that would be great.
Sure. So blood pressure is the number one regular or controllable risk factor for aortic dissection. And so patients who are at high risk dissections or have had previous dissections should always be counseled about their blood pressure and should know what their blood pressure is. Blood pressure is not a static number, as you know. It varies throughout the day and with activity. And so it's not only important to know what your blood pressure is doing when you're resting, but it's also very important to know what it does during your daily activities, with sleep, and with exercise. And so because it varies so much, what we actually recommend is for patients with aortic disease to have a 24-hour blood pressure monitor. That's an ambulatory blood pressure that you wear for one full day or even 2 full days, and it records your blood pressure in intervals. For that is that because blood pressure is so important, it allows us to prescribe blood pressure medications and time them to meet the time of greatest demand when blood pressure peaks, which is different for everybody at different points during the day. And so if we know that, we can actually space out the blood pressure medications and cover those areas or those times when the blood pressure is maximum and try to avoid the times when the blood pressure dips, which is also normal. Blood pressure goes up and down. And so if you're taking your blood pressure medicines at a time when your blood pressure is normally low, you're going to have more side effects, which also kind of limits the utility of blood pressure. So
that's really interesting because first of all, do you hear that feedback or is it just my phone? Just curious. Do you hear feedback?
I don't hear any feedback on my end.
Okay, then that's just me. Because you'll see people posting their blood pressure and some people will post, you know, I'm having a bad night. It's 154 over 92, which some of us can feel that. And obviously that's high. And if it's been running that way for an hour, 2, 3 hours, and you've been resting, it could be problematic. And then some people, their blood pressure goes really low to, let's say, 92 or 100. And they're actually people that'll say, I'm just not going to take my medication, not realizing that it's the medication that's helping to keep you low. And so after you speak to that, medication as well isn't like Tylenol. It doesn't necessarily go into effect within a half hour. So I think that's something that a lot of patients don't realize is that some of these medications, they start maybe 2 hours after you've taken them, some maybe even longer. So if you can talk to both of those thoughts that I threw at you, that'd be great.
Over 24-hour blood pressure tracing with a patient, what we will typically do is have them keep a diary of that period as to when they took their medications. And patients are always amazed when they see how long it takes for their blood pressures to actually come down after a dose of medication. Usually it takes several hours. And so if you take your blood pressure take your medicine when your blood pressure is high, it could be 3 or 4 hours before it dips again. So that is the reason why you try to time the medications to anticipate later in the day when your blood pressure is high. Like for instance, if it peaks in the afternoon, you should take your blood pressure at lunch, blood pressure medication at lunchtime, or even sooner, and the blood pressure you take at bedtime is going to affect your morning blood pressure. So really, it's a matter of adjusting your doses for 4, 6, or 8 hours in advance.
Okay, that is a really interesting point. And I'll tell you, a lot of patients, they're not told any of this information. And you guys that are out there listening can speak to this, but I don't think really many, if any of us, are given any kind of instruction when we leave. So this is why some of this is so important to the community. I am going to open it up to start asking if anybody has questions here. We're going to start with Sandra. She says, if bicuspid aortic valve has not been corrected, should it be corrected at the same time as having your ascending aortic aneurysm taken care of?
Well, we've followed many patients who've had their valves left in when their ascending aorta is corrected. And in my opinion, the vast majority should have them corrected at the same time, because we do see a lot of them deteriorate over time, resulting in the need for a second procedure. Now, fortunately, for people who have not had their valves corrected, there is a second option besides open surgery, which is the transcatheter aortic valve replacement that you might have heard of. And that is a catheter that can be used to replace the valve without having to go through the chest. We go through a blood vessel in the leg instead. That saves you from needing a second surgery. However, that is not a permanent solution for many people who have, especially those who've had to have aortic surgery at a very young age, like a lot of our genetic aortic disease patients. And so they might be looking at needing several of those procedures through a lifetime. So if you have the option, the most durable solution is still a mechanical aortic valve, especially for a young patient who is going to need to have that valve for 50 or 60 years. And that's not something we can deliver through a catheter at this point in time. It might change, but for right now, those valves tend to last 10 or 15 years. And so that means you might need several procedures for the rest of your life. And it's something to discuss with your surgeon for sure, if you think you're going to be needing an aortic surgery.
I'm sorry, so say that one more time. The mechanical lasts how long versus the PIG?
The mechanical valve lasts a lifetime. The PIG valves generally tend to wear out after 10 or 15 years at this point. And
Okay.
of course, it varies from person to person, but that's kind of the average as a rule.
Okay. Okay. I do apologize that I understand there's some feedback on my end. I don't really know what to do to fix it. So I'm sorry. What kind of heart rate is safe while jogging?
Again, that would depend on your blood pressure. So when we do an exercise prescription for patients based upon their exercise blood pressure, we typically recommend that they run on a treadmill while we take their blood pressures in the lab. That allows us to get blood pressures much more frequently than we can do otherwise. And you see that the blood pressure increases above 180, for instance. 180 is kind of the red line for exertional blood pressure. We would prescribe a heart rate below which the blood pressure is at a safe level. And that's totally an individual thing. So there's no one heart rate that we could just tell everybody is safe. It really depends on what your blood pressure is doing.
Okay. Amy asks regarding bicuspid valve hereditary. Her husband has a VAV. When he was a teenager, doctors heard him murmur and brushed it off as innocent. His bicuspid valve and 5-centimeter aneurysm was diagnosed at 51. His son, who's now 20, also had the doctors mention an innocent murmur. So assuming the son should get screened. And then her husband's 29-year-old daughter went in for an echo after diagnosis and had nothing. It does not have a bicuspid valve. So I'm assuming the son should get screened.
Absolutely. And it's important to note that the way bicuspid valves present can vary dramatically from generation to generation. So some people can have a perfectly normal heart and no aneurysm and have a very normal valve. Even if it's bicuspid, it can function normally for decades. Other people in the same family may have a very severe onset of a leaky valve or a sticky valve, a stenotic valve, even at a young age. And so you can't really predict how things are going to go. It's important to get checked.
Okay. Open heart, the only option when you have a thoracic aneurysm with no other valve issues. You still have no choice but to have open heart.
And now for an ascending aneurysm, that's true. For descending thoracic aneurysms that are on the descending aorta but in the chest, there are options to place stents without doing an open heart surgery. So it really depends on the location. But for ascendings, it's still true. We haven't come up with a completely foolproof way to avoid open surgery yet.
What is keyhole surgery? I thought I heard something about that.
There's a sleeve. Is that what you mean?
I thought I heard something where it was actually tiny. It wasn't fully open.
There's something called a mini thoracotomy, which can be used for some kinds of heart operations, but unfortunately not for aortic surgery because the hole has to be big enough to manipulate the aorta, and that's still not possible to do through a mini thoracotomy.
Okay. So for bicuspid patients, what is the size you would consider for ascending aneurysm, 5 or 5.5? And does 30 years young, should you have different criteria if you're 60 versus 30?
Absolutely. So one of the things we do is normalize the size of the aorta for body size and age, and something called a Z-score. For ascending aortic aortas, that definitely increases by about 1 millimeter per decade of life. So an older person should have a significantly larger aorta than a younger person. Having said that, 5 centimeters or 5.5 is still a large aneurysm at any age. So there is no strong evidence that replacing an aorta at 5 centimeters prevents a lot of events for a bicuspid aortic valve. On the other hand, we know that most people with large aneurysms are at much higher risk for dissection. And the biggest clue as to when you should do it is probably if someone in your family, if you have a family history, for sure you're at higher risk of a dissection. And if you have a genetic disease. So bicuspid aortic valves can be associated with genetic mutations that cause aneurysms, and in that case, you would be at higher risk for dissection. So if you have one of those two conditions, we do recommend earlier replacement in most cases. But without that, again, an elective, well-timed repair when it's convenient and not urgent is the best way to go. And that can really depend upon your life situation and things that are often not related directly to your medical situation. So it's better to discuss that and plan in advance. That's the best way to have a good outcome.
Okay. Another person says they had bicuspid valve replaced at 23, and the echo at that time showed an ascending aorta at about 5 centimeters. Now, after 8 years, it's 5.1 to 5.2. So that, as we talked the last time, that would be considered true growth, which I want you to get into in just a minute. I just made a note. Does it or should it be considered rapidly growing, and do you need to operate immediately, or should you just be watched with a CT for a few more years?
So that is not rapid growth. Rapid growth is defined as over 0.5 centimeter per year. Over that period of time, almost a decade, it is not rapid growth, but it is still a very large aneurysm. And so it seems, given the person's age, that it's almost inevitable that they will need prophylactic surgery. And the thing to consider there is that with each decade, the risk of the operation that you would need to replace the ascending aorta goes up. And so at some point, it makes sense to do it earlier rather than later to minimize the risk of the procedure itself. And to do it electively, of course, is always better.
Now, that doesn't mean that the valve necessarily has to be replaced. What determines if someone has valve sparing surgery, and what is that actually versus having someone's valve replaced?
So there are two kinds of operations that can be used in valve sparing surgery. So there is a situation in which the valve and the entire root, if it's not dilated, is spared and only the ascending is replaced. And then there's a more extreme situation where you have a normal normally functioning valve in a dilated root, and the entire root and ascending aorta is replaced with a graft. The patient's valve is then resuspended inside the grafted root. So in that case, everything is replaced except for the valve. In most situations, we encourage repair of any abnormal aortic tissue at the time of surgery. So if there's any slight indication that the root is dilated or appears abnormal, the surgeons will always err on the side of replacing the root because we know that the root would tend to dilate over time. And we also know that bicuspid valves tend to degenerate over time. And so if the valve looks abnormal, again, most people would err on the side of replacing it to avoid the need for a second surgery. As I said, the options for that, particularly in a young person, are not great either. So that's the reason why we would choose to replace it rather than squeeze a few more years out of a dysfunctional valve.
Okay. So you had mentioned that the lifespan, or like how long different valves will last. What about grafts and stents? How long do they typically last? If somebody had a graft done in their thoracic abdominal aneurysm 7 years ago, how long should people expect grafts and stents to last?
So grafts are, in general, very durable, but there are some exceptions. And so one of the things that can happen to a graft is that there's something called endothelialization. So the cells can grow on the lining of the graft the way they do inside a blood vessel. And if they proliferate too rapidly, the graft can start to narrow, or it can kink. In many cases, the same processes that cause atherosclerosis or hardening of the arteries can also affect grafts over time, particularly in the thoraco-abdominal aorta. And that can lead to stenosis or a lack of blood flow through the graft. But again, this process takes many years. It's not a rapid process. So generally, we're talking decades and not 1 or 2 years.
Okay.
Most of the stents and grafts are very long-term solutions, even permanent solutions for most people.
Okay. Nick has been taking his BP meds at night or before bed because it makes him too tired if he takes it in the morning, usually around 118/74 during the day. Explains that he takes, I guess, there's a lot here, but takes 1.25 of bisoprolol. I butchered that. Yeah. And then also had a leaky valve, tricuspid, that was supposed to be replaced with mechanical, but I guess they managed to save it and repair it after the arch replacement repair. Should he be good since it's his original valve and not PIG? He hopes he's good and doesn't need to have a new one.
Okay. I'm not sure what the question was.
Yeah. I'm wondering, I'm okay. I think I missed that too. So Nick, if it was a real question, throw it out there.
So fatigue is a main side effect of beta blockers in particular. Particularly in young people, a lot of them discontinue beta blockers because of fatigue, and we do recommend that they take them at night. But if bisoprolol is causing side effects, there are other beta blockers as options that could be used. I like to use 24-hour slow-release beta blockers. They tend to minimize the side effects in a lot of patients, as opposed to more rapid onset medications, because they provide a steady state level of medication throughout the day. So that's one option for fatigue. Another option is, of course, to use a non-beta blocker aortic medication like losartan, which would tend to cause less fatigue in most people.
Okay. So if the root of the aorta was replaced because of a dissection procedure, does this person need to be concerned with continuing to grow a new aneurysm in the remaining root? And I'm going to ask a question about that too. My root was replaced, and I guess the sinus of Valsalva has now grown, and I still have my valve as well. So where is the concern for things to continue to grow in that little teeny bit that's left?
Yes, so we've seen aneurysms develop in every part of residual tissue in a root. So for instance, one example we were just talking about is the valve-sparing root. So if everything is replaced, you would think that you were free of potential aneurysmal tissue, but the little buttons that they use to sew the coronaries on in several patients have become aneurysmal. regardless of the amount of tissue that's left, even a small amount of tissue is still potentially a source of aneurysm development. And so I would say, yes, if every bit of native tissue needs to be monitored as if it will develop an aneurysm.
And let's say that little bit that's left does and gets to the magic number, depending on rate in which it grows, or I guess the number would still be 5.5. Do you have to replace the entire graft at that point? Go back in and do the whole thing again?
You don't need to replace the entire graft, but you can replace, you would have to excise the aneurysmal tissue and replace that with a graft. And you can sew onto the original graft in most cases. And so it is still a big operation. And because it's close to the heart, it would require probably going on cardiac bypass. So it's not a small amount of work. Even though it's a small tissue area, it is a critical area, and so it needs to be repaired completely. So the message is that if you can, it's better to get everything fixed at once. Now, there are lots of reasons why it doesn't happen. There could be an acute dissection where it's an emergency, and the doctors are just trying to save your life, and so they sew whatever's available. And because time is of the essence, obviously, in that situation. And so that's understandable, but then that area needs to be monitored because it will never be normal.
Okay. Going back to the question we just had a few moments ago about the aorta that increased from 4 to 5.2 in 8 years, that's still not rapid growth, correct?
I thought you said 5 to 5.2. I'm sorry.
Yeah, no, so it's 4 to 5.2. So went up 1.2 in 8 years.
8 years is still not technically considered rapid growth, but I would be discussing with the patient, look, you're inevitably going to need surgery, and this trajectory is not a good one. And so I would make plans for elective repair well in advance. Start talking to them right away as soon as we found out that had occurred. Because if you extrapolate it, it won't be long before that patient is going to meet all reasonable criteria for surgery. Okay. And if people realize that and they can plan ahead, it's better for them to just go ahead and prepare as if they're going to have the surgery and arrange their life accordingly. It's much less dramatic that way, we find in most cases, for people to accept that.
And I would think in general, if you're somebody who has survived a dissection and now you're going to go back in for a planned surgery, that I would even think that the prognosis is probably better because it is planned and it's not so emergent and dire.
Absolutely. That's the number one risk for a bad outcome, is to have if you look at any sort of surgery, if you do it emergently, your risk is 5 or 10 times higher. So that's really what you need to, what we're trying to avoid is to take urgent and emergent procedures away and to have this be an elective, well-planned.
Okay. So how do you know for sure if it's a genetic issue? This Ginger says that her mom's aneurysm was found at, I guess, 4.1. They were doing valve replacement, and hers was found at 4.3 by accident. Both are ascending thoracic aneurysm, no other family history. I think they just met the criteria for more than likely being something genetic.
Right. So if we have a family history, we assume in most cases that there is a genetic cause, even if we don't understand what the gene is. So we only know about 25 to 30% of the genes that cause familial aneurysms in the absence, and most of them have no other signs or symptoms or other features, just the aneurysm. There are a few situations where we can find other problems that, if we do a head-to-toe exam, but this is a very typical case where we have aneurysms that run in the family and there's no other medical issue that we can identify. So more than likely, this is a genetic problem. And we often enroll those patients in our research studies because we're always learning something new with each family.
And so if you'd like information about that, well, actually, you know what? To my colleagues that are watching, we will post information about the John Ritter Research Program tomorrow as a follow-up to this conversation tonight. So for any of you watching or any of you who watch this replay video, there will be information tomorrow about how you can get in contact with the John Ritter Research Program. And it is free, and all that information will be on there instead of going over it tonight. We'll all be there for you to look into. Quick question. Severe gas constantly, can it be a symptom of an abdominal aneurysm? Or I mean, do you just go there, or you go with the GI issues first?
I would go with the GI issues first because they're still much more likely to be true. If you have a known aneurysm and you experience any unusual abdominal pain, it's a different story. So in that case, you should notify your physician. You should get assessed because, as I mentioned, a lot of abdominal aneurysms present with nonspecific symptoms. And so my counsel is always, if there's any new pain that you've never had before, or it's a pain that doesn't go away, make sure that you rule out that it's not coming from the aneurysm. It's a matter of common sense to protect yourself. In most cases, it will be a false alarm, fortunately, but there are some times when even experienced physicians cannot tell the difference. And so there's no general rule to say this pain is completely benign. We cannot say that.
Okay. And here you go. This is a great question. Adelino, if I'm pronouncing the name correctly. How is it possible that my ascending aneurysm of 4.2 has never grown in 12 years? And in those 12 years, this person has had severe high blood pressure, high cholesterol, and gained over 100 pounds, 54 years old. Luck?
Well, it is luck. It's also probably genetics. I mean, we know that people have very weak aortic walls genetically. We can tell that because when our patients have surgery, some of them have paper-thin aortic walls, and some of them have thick aortic walls. So that is clearly a genetic trait, and that would allow you to withstand, having thicker aortic walls obviously would allow you to withstand higher blood pressure for longer periods. Having said that, there is always a breaking point, and so it's still a risk, especially because we know dilated aortas are already under stress to maintain high blood pressure.
Beverly was told she has a TAA on her arch, 4.7 in 2016. I'm sorry?
You should definitely high blood pressure before it's too late.
Okay. So she had 4.7 in 2016. A year later, it was 4.8. Is 0.1 considered rapid growth? And should she see a cardiologist or a surgeon?
So not technically, but absolutely, you should see a cardiologist. I think it's premature to think that you might need surgery. It would depend on a lot of other factors, but you should get assessed for. They should take a history. They should identify other factors that might be contributing to this, and rule out other structural heart and blood vessel disease that might cause this to accelerate and become a problem.
So wouldn't 4.7 to 4.8, if I'm remembering our last conversation, that could just be someone's interpretation of the scan. It could just be the timing of the scan. What really, other than what you had said, I think you said 0.5 in a year, correct? What is true growth? When should someone be concerned? 4.3 to 4.6 in 6 months? Is that really growth, or is it, someone's interpretation? What is growth?
So we know from studies, from clinical studies of using the same image being read by different people, that 1 to 2 millimeters is kind of the range of error for just reading the same scan. Then if you get more than one scan, like from 1 year to the next, the range of error goes up to 2 to 3 millimeters. So it's not infrequent for someone's 4.5 to be someone else's 4.6 or 7. So if we see that, you would really need to have the same person read each scan to be sure that those are true differences. If they are true differences, then a difference of more than 2 millimeters in a year is substantial growth, because as I mentioned, for the ascending aorta, the average rate of growth is about 1 millimeter per decade. And so that's 5 to 10-fold faster over the course of a year. That doesn't meet the criteria for rapid growth that would demand surgery. Still abnormal.
Okay, I was writing that down. Okay, next question, valve question. Would he be okay having the valve spared, even though it was planned to be replaced with a mechanical when he had his 7.6 centimeter aneurysm on his arch replaced? Wondering if original valve would have been good long-term if it was spared. And I'm not sure if you would know.
Well, it would depend on the function of the valve. So if the valve was severely leaky, which is very likely if the aorta was that dilated, because it tends to pull the valve cusps apart and cause regurgitation, then it may not have been possible for the valve to be spared because there would be too much damage from the valve, the stress of the regurgitation on the valve. It actually causes damage that is irreversible over time. So most of the time in those situations, it is unfortunately not possible to spare the valve.
Okay.
But hard to tell without more information.
Is the lifespan of a person potentially shortened after a successful dental procedure? One of his surgeons told this person at 35 that they would be lucky to live 20 more years. And I remember this post. I read this online like a week ago and said that you'd be lucky if you get 20 more years, which it blew a lot of us away. I think a lot of us were very irritated and we were like, go get a new doctor, because that's a terrible thing to say and not necessarily true.
So the longevity of the surgery is much longer than 20 years. We know that because we've had survivors who've been 30, 40 years out with grafts, and they're doing fine, even with mechanical valves and grafts. And so I can't understand why he would have said that. There might have been something else, some other related, to lifestyle or other kinds of medical conditions that would shorten. Really, after a successful repair, 20 years is the bare minimum. You should certainly expect the aorta to hold up longer than that.
Okay. I know, 20 years, it was really very upsetting. Can a TAA cause back muscle spasms or shoulder spasms?
It can definitely cause back pain. We've seen that quite a bit. Many times it's confounded because a lot of people with aneurysms also have back problems. They tend to put together because issues like scoliosis in people with aneurysms. So we definitely take it seriously, and we do evaluate them for any changes or evidence of dissections or other kinds of problems when they do present with new back pain. But again, it's a matter of being accustomed to what is normal for you. Is this everyday back pain, or is this something different? If it's something different, then you should definitely get it checked out.
Okay. Here's an interesting question from Cheryl, and we're almost going to be, I think we're wrapping up here. So if you've got any last minute questions, you might want to get them in now, or better yet, type them out. Sorry for the feedback. Type them out, and Dr. Prakash has access to this page, and he'll be more than happy to answer them as he has some time. Coming back from the holiday, I'm sure you're very busy. So Cheryl had vein ablation in both legs a month ago, and since then her blood pressure has been crashing, and pulse has been staying around 40s or 50s. Crashing for her was 106 over 50. She's not been hungry really at all since then. Only eats because she has to. She's lost 30 pounds. Not sure why this is happening.
Okay, well, it sounds like that's more than just maybe related to the procedure, that there's another medical condition going on. Things like abnormal electrolytes or abnormal kidney function can definitely present with some of those symptoms. And so it sounds like she needs a good head-to-toe exam and maybe some other tests to figure out what's going on. This is quite a big change. And so anytime that happens, you need to be reevaluated.
Antibiotics. So if you don't have a mechanical valve or you still have your own valve, are antibiotics important, let's say with dental procedures or any other procedure?
This is a great question, and we are actually changing our position on this. As you know, over the past couple of years, several articles have come out saying that patients with abnormal valves, including bicuspid valves, are at increased risk for endocarditis. And we know that having a prosthetic valve definitely puts you at risk. Many of my patients do take antibiotics before dental procedures, although interestingly enough, even with the change in the guidelines so that fewer people are taking antibiotics, there hasn't been a drop in or a change in the endocarditis rates. It hasn't gone up, but it hasn't gone down either. So it seems that it may not be the key factor that we once thought it was, but people are definitely at increased risk, and we just don't know what to do about it right now.
And you say abnormal valve, meaning bicuspid, or also just meaning it's like severe insufficiency?
That's right. So patients who have any sort of valve disease, if we look at compared to people without any problem, are at much higher risk to develop endocarditis in their lifetimes. The problem is we just don't know what to do about it. We thought maybe it would be antibiotics at dental procedures, but that doesn't seem to be fitting or having an effect that we want. So it could be exposure to bacteria at other times in your life. We just don't know how to be effective about it. If we tell people to take antibiotics all the time, the antibiotics won't be effective. We just don't know what the timing needs to be to prevent endocarditis at this point.
Okay. So Betsy's scheduled to have a biopsy in her neck and wants to know if she should replace antibiotics. She had a dissection about 8 years ago, has a aneurysm now hovering at 4.8.
So for most things like skin biopsies, we don't recommend antibiotics because they're not considered to be, they can be done in sterile conditions under, good control. And so for those types of procedures, we don't generally recommend antibiotics. And the reason, again, is that if we use antibiotics all the time for everything, they'll stop working for everybody. So we do have to be really careful about resistance, and that's the reason why they try to limit it. And again, there's no evidence that an antibiotic in that situation would actually do anything. We don't have the data that it would prevent any sort of endocarditis. Okay.
We've discussed this before. Obviously, having multiple CAT scans is not necessarily great, but if it can save your life, it's great. What are the side effects from too many CAT scans or too many MRIs, what's perceived to be too many?
Okay, the side effects of many CAT scans, and by many I mean 3 or more in your life, is an increased risk of cancer. It can be documented and it's measurable. It's up to a 20% increased risk. It's not trivial. And so people who are getting serial CAT scans need to be counseled about that, and they need to understand the risks. Now, most of these will show up later in life, and so it's not sort of an immediate cause and effect thing. It took many decades of research to actually get this down, because you need to follow patients for a long time. But we do know that later in life, the risk will go up as a result of early exposures to radiation, including CT scans. And there's still a lot of radiation. Even in the newer machines, it's like getting several x-rays at a time. So most of us don't ever see that much radiation in our lifetimes. Go ahead.
Right. I'm going to ask 3 more questions, and then we're going to let you go. Do people have their entire aorta replaced? The whole thing?
Yes. There are a few people, unfortunately, whether they're lucky or unlucky, is a matter of perspective, who have had their entire aorta from the root to the iliac bifurcation replaced, with stents below that. So it is possible, but it takes several stages of the operation over many years.
What are the chances of an aneurysm staying stable and never growing? So you find growth, but then it just stops growing.
Actually, pretty good. So from what because we're picking up a lot more incidental aneurysms, we have a lot more observational data than we used to. And for small to medium-sized aneurysms, the growth rate is surprisingly small. Many of them never need intervention. So I often counsel my patients that being diagnosed with an aneurysm is not as grim as it sounds, particularly if it's on the smaller end of an aneurysm scale. A lot of times those do stabilize.
Okay. Final question of the night, because we have to let Dr. Prakash go before you'd like to have dinner. What is your opinion? A 34-year-old has a thoracic aneurysm, and she wants to have a child. Cardiologist recommends not to do it. It is a genetic issue, which unfortunately took her father's life, and is also affecting her aunt and her brother. What would be your thoughts about having a child?
So I think she needs to have a significant counseling, both by a geneticist and cardiologist. And so obviously there's a risk for her to transmit this to her child, and that needs to be explained and addressed. And there are lots of ways to address that. From a cardiovascular point of view, there are a couple of things that we could discuss. The first is the possibility to have prophylactic surgery before delay the pregnancy. It is still unclear, actually, as to how effective that may be. We're trying to get more data about it. There are several new registries to enroll women with aneurysms who do become pregnant, so we can understand this. But the consensus has been that if you do have a large aneurysm, that is something you should at least discuss with your cardiologist. The other option for sure would be get strict medical therapy before the pregnancy. We recommend getting on a medical regimen like a beta blocker that is compatible with pregnancy, and making sure that your blood pressure is well controlled. And then to have consultation, preconception counseling, as well as monitoring throughout the period by an experienced practitioner with aortic disease, and plan to deliver in an aortic center with expertise in aortic surgery. So those are probably the main recommendations. We just, at the European Society of Cardiology meeting, they just presented new guidelines for congenital heart disease, including aneurysms in women who are pregnant. And that was probably the strongest recommendation, to go to some place that sees these issues, because it is kind of rare for a lot of practitioners.
Okay. Dr. Prakash, thank you so much. Every time we talk, I learn something new. Might not be something I'm excited to learn, but I learned something new. And I think that the community, I know, really appreciates you taking your time. And again, everybody post questions if you have them, but I will let you know that Dr. Prakash will be doing our Ask a Doctor segment in about 2 weeks, and we will be posting that date soon. And about a half hour, 45 minutes of your time, you're just going to have an opportunity to type your question, and he's going to text you right back an answer on the post on Facebook. So that's something new for us and new for him with us. But again, thank you so much for taking time out of your night right after the holiday to answer some of these questions and talk about aneurysms with us. We greatly appreciate it.
My pleasure. Good night, everyone.
Good night, everybody. Thank you all so much. Have a good one. Bye-bye.